Okay. We're going to talk about the heart quickly. I've got about 30 minutes or so I'm going to go through this relatively fast. Yalda, 26-year-old female, comes in. She's got shortness of breath and chest pain. She's a school bus driver. She's on oral contraceptive medications, recently started taking them. She's a heavy smoker. Those are her vital signs. She's tachycardic, hypotensive, tachypnic. Her lungs are clear. And what do you think is going on? Pulmonary embolism? Anybody disagree with that? No? You've already seen this lecture? All the interns have seen it. That's right. Oh. Maybe I shouldn't do this lecture then. Yeah? All right. All right.
But we all disagree.
You all disagree. That's good.
I agree
Well,
with y'all.
You agree with the Alda? Okay. So can you put someone like this in the CT scanner who's got... you could, but... Have the medical students seen this too?
No.
Oh, good. Okay. So what does a PE look like on ultrasound? What happens? Normally you've got the left ventricle and you've got the right ventricle. The right ventricle about 2/3 the size of the left ventricle, correct? You with me?
Yes.
So what happens during a massive pulmonary embolism to cause this derangement of vital signs? So the right heart gets like bigger than the left heart. Okay? So if I had a patient who's unstable and I thought they had a PE and I couldn't get a CAT scan to confirm it before I pushed thrombolytics, because thrombolytics are indicated in shock, okay? So I actually had the nurse get the thrombolytics out for this patient, and the father's asking me, well, are you sure it's, this blood clot in the lung? I said, well, yeah, it's got to, clinically I really think that's what's going on. How do you diagnose a CAT scan, but we can't put her in a CAT scan? He was like, well, is there anything else you can do? And then I was like, oh yeah, I can do an ultrasound. And so I brought the ultrasound machine over, and I did this. Wah, 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 wah. So, excuse me, nurse, did you already push the thrombolytics? No? Good. Because that would have been the exact wrong thing to do, right? What does this patient need? Pericardiocentesis. So, this was a real case. Maybe it was just me being a poor clinician, not being able to figure out the difference between PE and tamponade on a hypotensive patient. Or maybe everybody would have struggled with that and been led down the wrong pathway. I really looked like PE to everybody in the room, but we were all wrong. Actually, and the ultrasound really saved us from pushing thrombolytics, because then it would have been really difficult to do a pericardiocentesis on somebody we just gave thrombolytics to. We would have had a real problem with sort of the reaccumulation and that kind of stuff. So that's a good reason to think about why we should be doing cardiac ultrasound, because we had the ability right there to integrate the clinical picture with the ultrasound findings. We know sometimes it's difficult to get cardiology to come down and do a stat echo depending on the time of day. And by stat, maybe it gets done in 15 minutes, maybe 20 minutes. I don't know. Stat for me means in the next 60 seconds. And so also, like in that patient, it was an unexpected finding that we had. And I think all that makes you a more accurate physician, the only limitation being your knowledge. We had a case of this just recently in a patient who came in, was this 2 days ago? Yeah. Who had fatigue. I just reviewed today during QA, who the students were sort of looking at the gallbladder and other structures, and there's a great ultrasound image of them looking at the gallbladder, but off in the distance towards the bottom of the screen, you can see something, you can see a big fluid collection with the heart beating in it. And then they focused on the heart, and this was pericardial tamponade, and the patient went to the cath lab and had a pericardiocentesis done in the cath lab as a cure to their fatigue. And so this was an undifferentiated patient. The medical student just happened to be scanning, sort of going bed to bed, and picked up that 2 days ago. Would that have been discovered with a thorough history and physical? Maybe, maybe not. Maybe it would have been delayed for a few hours, but the patient immediately went and had this procedure done 2 days ago. So that's a good reason to be doing this stuff. There's all these educational standards out there from the American College of Cardiology and American Society of Echo, but the American College of Emergency Physicians wants 25 exams. The idea is you want to get as good as you can and start to understand some of your limitations with cardiac ultrasound, which we'll get to. The indications to do cardiac ultrasound, any of these situations where I've got a patient in PEA or cardiac arrest or unexplained hypotension, maybe there's an effusion, whether or not it's tamponade, patients with chest pain. Respiratory distress is probably my most common reason why I do a cardiac ultrasound, believe it or not. Unexplained dyspnea. At least 20% of the time, a study has shown that with unexplained dyspnea that you're going to get a pericardial effusion there. And so when it's unexplained, when you don't have another reason to have dyspnea. So, and of course with trauma. But stuff we're going to leave to cardiologists, you know, stuff with the heart murmur. You come out of the room and go, hey, the patient's got a heart murmur, want to go look at it? Yeah, I mean, I'm sort of curious a little bit, as any doctor would be, to look at the heart, see what the murmur looks like. But really, to differentiate how much TR, MR, 1+, 2+, really those things have no clinical bearing for me as an emergency physician, and it's easy to misinterpret those kinds of color flows across of the valves. So other things like early diastolic dysfunctions, endocarditis, I've hallucinated hundreds of times now. Just stay away from that stuff unless it's super obvious. Where do we put the probe? Well, there's the subcostal 4-chambered view that we're very used to, as well as the parasternal long axis that we're very used to with the cardiology. With the trauma exam. But looking in the parasternal short and at the apical 4-chamber, that's something that we're definitely going to want to focus on in this lecture as well. So what cardiac ultrasound views, how do we define them? Well, they're defined by the structures that you see when on the screen, not the position of the probe on the skin, because everybody's got a different chest wall shape, and really what you're looking for are certain patterns on the screen, more so than exactly where to put the probe on the chest. Because some patients, the parasternal long is going to be the second intercostal space. I've found it all the way down to the 5th, 6th intercostal space, believe it or not. It's very patient dependent. And most patients don't have all the views. Some people have really nice subxiphoid views. They've got a big liver, and I can see their heart really well subcostally, but they're a heavy smoker, and I go look parasternally or apically, and there's no heart because the lung expanded to take up my cardiac view on the chest. And so that's why patients who have COPD, who are intubated, often have very challenging parasternal or apical views. And you watch a cardiac sonographer, you know, do an ultrasound. They always roll the patient. They stick a pillow under their right scapula, roll the patient left lateral decube, brings the PMI to the chest wall. You can always get better views if you roll the patient to their left. That's the big secret here. Not unlike looking for the gallbladder. The liver is the window to see the heart. We use that liver as our window in order to see the heart. So whenever I do a subxiphoid view of the heart, I'm not looking at the left side of the body. I'm looking right underneath the xiphoid process, using the liver as the window, shining the beam towards the patient's chin with the indicator to the patient's right. Okay, and that's what a subxiphoid view looks like. We can see the 4 chambers there. This is the right ventricle, right atrium, left atrium. Here's the posterior wall of the left ventricle. The apex is over here, and this is all the liver. Now, the trick to seeing that subxiphoid view is start over at the liver edge and follow it up into the subxiphoid margin. And so you look first at the liver, using that as your window, and then once you're in that subxiphoid notch, have the patient take a deep breath and hold it, aim the beam towards the chin, and this is what you see. We can make out here the right ventricle, the left ventricle, the right atrium, the left atrium. Here's the liver, and this whole thing around here is a large pericardial effusion. And that's the main stuff we're looking for. Here's another example of a subxiphoid view with a pericardial effusion. We can make out all 4 chambers. We're using that liver. We see a lot of liver at first, and then we go into the subxiphoid notch where we see more of the apex. Without this liver, you cannot see the heart in a subxiphoid approach. So someone who's got a very small cirrhotic liver, you can't get these windows. The problem is when you have somebody who's a big drinker and a big smoker, where now they've got a tiny cirrhotic liver, and now they've got these huge COPD lungs, and then you're wondering if they have a heart in there at all. It's hard to find. You really got to roll them left lateral decube, have them take an enormous breath and hold it, which of course they can't do because they're such bad COPD, and this whole thing becomes a very challenging exam. When you have a nice view of the subxiphoid, though, this is the kind of stuff you're looking for. Again, RV, LV, RA, LA, and we can see the mitral valve between the LA and the LV, the tricuspid valves between the RA and the RV, the liver being at the top of the screen. Now, parasternal long, we're going to aim that indicator along the long axis of the heart with the indicator down towards the patient's elbow, and that gives us that long axis. It's at the 3rd or 4th intercostal space, generally speaking. The indicator to the patient's left elbow, sometimes it's towards the patient's left hip in that general vicinity. You're going to see a 3-chambered view of the heart, the RV, the LV, and the LA. And this is really the best way to make out what the valves are doing. And we spent a lot of time talking about the peristernal long axis at the end of this lecture, which I'm going to jump to here shortly. We can see there the left atrium, the left ventricle. The blood is basically starting from here, going into that left ventricle, then being pumped out the aortic outflow tract, with the right ventricle here seen at the top of the screen. It's a three-chambered view of the heart, and once in a while you can make out the descending aorta seen down here posteriorly. Here's an example. This is not an actual ultrasound. This is a schematic view of the heart moving. LA, LV, aortic outflow tract. We can see the anterior septal leaflet of the mitral valve right there. That's a very important landmark when we talk about contractility. What chamber lies right here? RV, very good. And that's just another view of it here. But I like this particular heart here. This is a little tachycardic. LA, LV, aortic outflow tract, RV. That's the interventricular septum. And this back here is the posterior wall. I don't know, I can't really see that the descending aorta. It's in around here somewhere. I'm not seeing it very well in that view there. But this is just a normal peristernal long axis. This is what it looks like when you've got a pericardial effusion with the peristernal long axis. We can see the fluid actually on both sides of that heart. So the pericardium, I'll trace it for you. It's out here, kind of falls off the screen, and then it's down here. And the fluid runs anterior to that descending aorta. Because if the fluid runs posterior back here to the descending aorta, then you've got a what effusion? Not pericardial, but pleural. Very good. So the fluid runs behind the descending aorta, that's pleural. If it runs anterior to it, it's pericardial. The short axis is just like the long axis, except now we have the indicator aimed to the patient's right. So you start from that left elbow in the peristernal long, and then you rotate it to the patient's right elbow, 90 degrees from where you found the best peristernal long. And basically, you're going to see the right ventricle, you're going to see the atrium seen very easily, and also the left atrium. You can see down to the aortic valve, which is the Mercedes-Benz sign. Sometimes you can make out the pulmonary valve as well. This is a still image here of that Mercedes-Benz sign. This is the aortic valve seen right there. We can make out the left atrium, the right atrium. This is all the RV out here. And as we go a little more distally, then we can make out something called the fish mouth view, or the mitral valve. So this is the peristernal short. We're seeing down towards the apex. Now we're seeing the apex down here, and then we're back up to that mitral valve. If we go even more proximally in the same axis in the peristernal short, all we need to do is fan the probe more proximally, then we get up to the aortic valve, or Mercedes-Benz sign, with the RV seen up here. Again, it's looking like a donut coming to a center point. You see how that donut comes to like an imaginary center point here? That's the peristernal short axis. We can see the mitral valve, and then we can see the aortic valve in that same plane if we just fan it anterior a little bit. This is an example here of what it looks like when you've got a pericardial effusion in the peristernal short axis. Of the four views of the heart, this is probably the one I use the least amount to do my work. However, just pointing it out for the sake of being complete. However, the apical forechamber is quite good for comparing chamber sizes. You place the indicator of the probe towards the patient's right hip, with the probe placed just at the apex of the heart, usually right around where the nipple would be, the patient's nipple, just inferior to the patient's nipple there. And it's a coronal view of all four chambers. You've got the heart lining up vertically up the screen with the apex at the top of the screen. And this is when you can really see that the RV is about 2/3 the size of the LV. It's good for the overall function. You can see the atria, the valves. Sometimes it's hard to get this window, but this is what you're looking at. The indicators to the patient's right. We've got the septum of the heart right here. LV, the RV looking nicely 2/3 the size of that LV with the atria below it. This is a schematic view of what's going on in the LV and the RV and the atria with its valves seen there in that apical forechamber. And this is what happens when you've got a pericardial, pretty big pericardial effusion. The heart is actually swinging back and forth. That brings up the concept of electrical alternans. Yes, in this patient you did see electrical alternans. However, what's the most common EKG finding with pericardial tamponade? Low voltage EKG, because of the electricity is just not making through all this fluid. So, but this is what it looks like on the apical forechamber when you've got a big pericardial effusion. This is an example here of just a nice normal apical forechambered view here. We see the LV, the RV with their corresponding atria down here. Just bask in that nice view. Tell me what you think. Are we ready to move on? I think we are. What are we looking for whenever we do a cardiac ultrasound? Well, we're looking for pericardial effusions, whether or not there's tamponade, whether the heart is standing still, any RV dilatation, for that matter RA dilatation, any hypokinesis, obvious tumors, clots that are super obvious, like and also vegetations that are just screaming at you, and maybe a congenital disorder or two. What can we see with pericardial effusions? Well, they're caused by a variety of reasons, but acutely, the unstretched pericardium can only accommodate up to 200 cc's before the pressure in that pericardium takes over the pressure in the right ventricle, and then the patient's blood pressure starts dropping. The longer it takes to build up, though, the more the patient can tolerate. So if it's a long chronic effusion, like somebody who's got renal failure, who develops uremic pericarditis with pericardial effusion, they can have up to a liter or two in their pericardium before they get tamponade. And what you're looking for is diastolic collapse of the right heart. So as you know, during diastole, when you expect the ventricle to fill, it actually tense downward. It looks like a trampoline, like somebody is standing on the right heart, jumping up and down on it. You have to differentiate this from epicardial fat, which can be sometimes difficult to do. This is an example here of a pericardial effusion. We can see that there are some loculations going on out here in this pericardial effusion. Here's the right ventricle, left ventricle. This is all the liver seen up here. Just an example here. This is probably a chronic effusion. Why do I say that? Well, there's loculations in there, and that makes me wonder how long that thing has been there. As I mentioned, if you take 500 patients who are considered high risk for a pericardial effusion, it turns out that 103 of them will ultimately have a pericardial effusion, and emergency physicians were able to do this with pretty good accuracy, 96%, 98% sensitivity and specificity, and that was after a quick lecture and some hands-on. And then another study by Mike Blivis showed that if you take patients who have a negative workup for any cause of shortness of breath, 14 out of 103 had pericardial effusion there. And so this is somebody who has unexplained dyspnea, 14 of 103 having pericardial effusions. And that's something to consider. How large or small the effusion is obviously plays into it. This is a very large pericardial effusion here in a patient who had stable vital signs. There's another finding as well. What do you guys see here? Good, a pericardial effusion seen just laterally there as well. When you're talking about pitfalls of pericardial effusion, you want to worry about any echogenic material there in the pericardial space, because guess what? Fat can mimic a pericardial effusion because you'll see a separation between the myocardium and the pericardium, but the fat is tacked down to the heart and moves together with the heart. You want to worry about any blood collections, loculations in that area. You want to be careful not to overcall these things, and especially in the setting of trauma, send a patient for an unnecessary pericardial window or even thoracotomy. And so that's why we got to be very careful here. This is what it looks like, though, if you have a clot. This is a patient with pericardial tamponade. Why do I say that? Look at the RV. It's bouncing up and down like it's a trampoline. Somebody's jumping up and down on it. This is the pericardium seen out here, and this is echogenic material here that is clot. We also see there's fluid as well as some epicardial fat. That's epicardial fat right there. This is some anechoic fluid, and that's isoechoic clot. Burn that clot in your mind, because that's something that someday you're gonna come along and you're gonna go, geez, I don't know if that's clot or if that's just epicardial fat. This is an example here of an epicardial fat pad with an effusion. Here's that fat pad. It's riding just along the outside of the heart. This is the pericardium along here, and there's anechoic fluid seen between the pericardium and the myocardium with epicardial fat pad. Luckily, these fat pads usually aren't more than 1 centimeter, but they're typically heteroechoic as opposed to a pericardial clot that's isoechoic, as we saw earlier today in that hemorrhagic ovarian cyst, very, very isoechoic. So with tamponade, you can have a large chronic effusion. Again, you're looking for RV collapse. There's something called Beck's triad. Anybody remember what Beck's triad is? Hypotension, muffled heart tones, and JVD that's present less than 1/3 of the time in full-blown tamponade. And so the physical exam findings, again, you got to worry about not being that accurate, and you want to look with ultrasound to rule in or rule out a pericardial tamponade. This is an example here of the tamponade. Notice again, it's this jumping up and down trampoline effect that's easy to see on the screen to say that there's diastolic collapse. It's just another example here of a pericardial effusion that the heart is swinging around in that pericardium. That also kind of hard to tell whether there's jumping up and down here or not. What else do I do to differentiate pericardial effusion from pericardial tamponade? Simply a blood pressure. If the patient's hypotensive or unstable and they've got a large pericardial effusion like that, I start to wonder if that's the cause of their instability and that the only cure is going to be a pericardiocentesis. In this case, the image quality is so terrible, I can't really tell if there's a trampoline effect going on. Looks like there probably is. It's such a large effusion, I'm very clinically suspicious that that's what's going on. How about this one right here? This next one here shows, hard to tell what's going on, but this is the pericardium out here. Here's the myocardium. The heart's really not able to fill that well. This also is pericardial tamponade, and there's, based on the patient's blood pressure, and also the fact that this is a several centimeter pericardial fluid collection. Is that clot in there? It's starting to look like it, isn't it? This is sort of isoechoic with the liver. Is it artifact versus clot? Hard to tell. This is off the Sonocyte Micromax machine. It's it's about 4 years old technology now. I would definitely step it up to the Sonocyte Turbo technology that we have also in the ED and take a look with that better machine that uses the P21 probe, and that's what I would really be curious of in that case, of a clot actually in the pericardium. Well, what about cardiac arrest? We do cardiac ultrasound on all our codes throughout the hospital now. We're looking for cardiac standstill or something else that we didn't even expect during the code, like a gigantic RV or pericardial effusion, which is why this is helpful in PA and can be helpful in calling the code. I did a study a few years ago. We enrolled 169 patients who came in cardiac arrest, and of those, 100 and we did ultrasound on all these patients, looking at their heart, and we also threw the kitchen sink of ACLS at every single one of these patients, regardless of what we saw on the ultrasound. But when we went back and looked at the data, it turned out that if you had cardiac standstill, or if you misspell it as sandstill, which actually got through the editorial process.
Inferior journal.
That's right, yeah. It's academic emergency medicine. If you had standstill, or standstill, you survived 0 times. Okay? But it was a small study. And then another study was done by Phil Salin et al., colleagues of mine, John Rose and those guys, who did a similar study, basically the same exact concept, but they looked at if you had no return of sonographic cardiac activity, no matter what your rhythm was, you did not have ROSC positive. You did not have return of spontaneous circulation in any patient. Not a single one. Again, small numbers, small studies. There's a study going on right now. There's 61 sites. We're one of the sites looking at this exact same concept called the REASON study that Rod Mortazavi's, one of the medical students, is sort of in charge of. And so we're looking at that now as one of the many centers doing this to try to find, is there any situation in which a patient could actually survive who had cardiac standstill on their ultrasound. This is what it looks like right now. Would I see this ultrasound and immediately stop the code? All depends on the clinical situation, and you have to kind of feather that into that. If this is a 3-year-old who is a drowning victim in cold water, no way would I ever stop that resuscitation based on cardiac standstill. If this is a 98-year-old from a nursing home who's, got multiple medical problems, and I see this cardiac standstill, obviously, in that extreme situation, I'm done with the code. And so it all depends on the situation and how you want to feather it in. This may be a way to end the code. I use it kind of the other way around. If I've got my nurses are kind of rolling their eyes at me like, come on, Fox, we've been running this code now for 20 minutes. Can't we call the code? I look at the heart, and the heart's actually moving. Then I say to everybody in the room, look, the heart's moving. We got to ramp this code up. We can save this guy, right? That's kind of the other side of the equation I tend to use it a lot on, is trying to keep the drive alive, so to speak. And then, after we flogged a patient for a few rounds of ACLS, if we see the heart is standing there, it sort of makes everybody feel better about stopping the code, and the family as well can be brought in, show them what a cardiac standstill looks like. That's something else to consider. Pulmonary embolism, we know that in patients who have defined PEs, massive PE, they go into shock. Thrombolytics are a recommendation by our college to push in the setting of PE and shock. You cannot hang your hat on a negative study, however, because you can actually have a PE and have a totally normal transthoracic cardiac ultrasound. Okay, be very careful there. Don't say, oh, I don't think it's a PE because the heart looks, I didn't see a large RV or RA. It's only when it's positive that it helps you out. And that's true for a lot of things we do in emergency ultrasound. We can rule things in that case. This is a patient who's going to have a massive PE, who's got a very large RA-RV that's approaching or even bigger than the LA-LV. Okay? The apical 4 chamber is really a great view. I like parasternal long also. thinking in mind that COPD, pulmonary hypertension, that could give you some false positives. This is what it looks like. This was an employee of the hospital who had an external fixation device on his leg, 41-year-old male. He went home after orthopedic surgery. 2 days later, he came back in full-blown cardiac arrest, PEA. We're doing CPR on him, and we saw his heart with no pulse. Now, about 30% of the time, you don't feel a carotid pulse, but you actually see this amount of cardiac activity. So this is called PCM, pulseless cardiac motion. It tells me the patient's still alive, okay? I don't know why they're not having a carotid pulse. It's not enough blood pressure to make a carotid pulse, but about 30% of the time, you will see cardiac activity, organized good cardiac activity like this, yet no carotid pulse. I shouldn't say good cardiac activity. This is very weak cardiac activity. But what do we see here? This is actually trying to be an apical four-chambered view. It's a little bit off to the side. This is the septum of the heart here. We could decrease the depth, but you know, in the heat of the battle, you get what you get. This is the left ventricle. This is the right ventricle. If you look here, it's kind of subtle. It's hard to see, but the RV is actually a little bigger than the LV. So in this clinical setting of an X-fix on this young guy who's in cardiac arrest with a large RV, we push thrombolytics, and 2 hours later, the patient was upstairs in the ICU, extubated, eating dinner. And an employee of the hospital, you know, made a big deal and all that stuff. Here's another patient here with a very large, this is the apical four-chamber, very large RV. The LV is almost gone. Here's the peristernal long, very big RV, small LV. It's going to go back to the apical. Here's the apical four-chamber, big RV, small LV. This is a patient with a massive PE, small LV, big RV. Okay? Here's another patient in cardiac arrest who we thought could have a PE, very large RV, very small LV. We pushed thrombolytics. Guess what? Patient still died. We're going to finish this lecture off with kinesis. Okay? Kinesis. I've got a patient who's hypotensive. Do I give them fluids or pressors? That's kind of like my first branch point in my head when I've got a patient with hypotension. And I can help that branch point one way or the other using this kinesis assessment. Well, I'm going to look at the mitral valve, the anterior septal leaf of the mitral valve, and how well that comes up and smacks into the septum of the heart. I'm also going to look at the sequentiality of the aortic valve and the mitral valve, how well they work together, and I'm going to look at the LV and sort of how much squeeze is going on in the LV. Okay, so here's how I do this. And I do this in the peristernal long, which is actually my favorite window of the heart, and one of my favorite things to ever do on with any ultrasound is a peristernal long axis. You can see here the apex is kind of hanging off this way, indicates the patient's left elbow. That's why we're doing this peristernal long. Here's the RV. Here's the LV. This is the LA. Here's that anterior septal leaf of the mitral valve. Now I'm going to focus on this area right here first, and I'm going to see how well that septum comes up and that septal leaflet comes up and smacks that septum. If it does, great, which it's doing, good. And the sequentiality between the mitral valve and the aortic valve. Do they fire at the same time, or is it sequentiality? I see some pretty good sequentiality there. Then I come over here and I look at the septum and the posterior wall. How well do these two things contract towards one another? So here's the septum, here's the posterior wall. Do they squeeze together? Yeah, pretty well. So this person right here has got a normal LV function because of the motion of that septal leaflet hitting the septum of the heart and the septum and the posterior wall coming together. Now let's look at another heart and do the same thing. How's that septal leaflet doing? Is it coming up and smacking the interventricular septum? You know what? It gets very close. It's got some good movement. I'm going to say yes. Okay? Is there sequentiality? You know, I don't think so. They seem to both kind of fire at the same time. So I don't see like one then the other. Then I'm going to move on here. So first of all, we look there and we see good, decent anterior septal leaflet movement, but we see loss of sequentiality. Then we come over here to the posterior wall and the interventricular septum. Are they squeezing together? Not very well. They're not coming together and making that big squeeze the way that the other heart did. That posterior wall and septum are not really moving much at all. And in fact, the tip-off here is that that septum is extremely thick. This is a patient with cardiomyopathy. And so whenever you can see the heart that beautifully, I'm always a little suspicious because big cardiomyopathic hearts are beautiful on ultrasound. They come across like this. You can see them very well. And so right off the bat, I'm a little suspicious. So if this patient was hypotensive in my ED, I would really consider inotropic therapy. As opposed to that last patient, that we saw that had normal LV function, if their blood pressure was 70 or 80, I would really be considering what? Fluids. Okay, what about this? How's that septal wall doing? This isn't the best view of the heart, but even though it's a little squished, I'm not seeing it come up here to the septum. Okay, so right off the bat, there's a problem. And by the way, the reason why I look at that, it's the physical mechanics of the flow of the blood going from the RA to the RV. As it moves through that from RA to RV, I'm sorry, right, LA to LV, as it's being sucked through that valve, it smacks that valve up against the septum. If it's going through with a good enough velocity to do that, good enough pressure change from that LV working so well, it causes that septum to that septal leaflet to smack the septum. So when it's not doing that, we know there's decreased LV function. Does that make sense? So then we come over here to look at the posterior wall. How well is that posterior wall hitting that septum? Not at all, right? It's basically, I'm surprised the patient even has a blood pressure sometimes when I see these things. So this is definitely a low ejection fraction. Qualitatively, I can say that. Quantitatively, I'd have to drop a bunch of discs or do the Tycholz method or do some other fancy calculations that takes a little bit of time. I don't really have the time to do that a lot of times, and so I just look at these things qualitatively and decide if it's a low ejection fraction or not in the setting of hypotension. How about this next one? Okay, septal leaflet coming up. Pretty good, hitting that septum pretty well. Okay, good sequentiality going on. How about the LV and the septum, interventricular septum? Yeah, the heart is emptying with each beat. See how they actually touch each other there. And when they touch each other like that, and this patient's blood pressure is 70, I know that I need to right away get some fluids going, right? This is a dry heart. It needs some fluids. A normal EF that's very thirsty heart. This is just a very obvious example here of very low ejection fraction. I'm wondering to myself, does this patient have a pulse? They've got basically no anterior septal leaflet motion at all. And I don't know what's going on over here, that posterior wall and the septum. I'm thinking inotropic therapy, you know, right away if this patient's going to survive. Also, the RV looks very big compared to the LV. And I'm thinking about, you know, clinically, does this fit into a picture of pulmonary embolism with the rest of the patient's presentation factors? How about this one here? Normal. I know I'm running low on time here, so I'm going to wrap it up. But this is the septal leaflet of the mitral valve coming up, smacking the septum of the heart. It's kind of hard to see the aortic valve. Not sure if there's sequentiality here, but I'll tell you what, that septum comes in and squeezes pretty close to that posterior wall, and this makes me feel pretty comfortable that this ejection fraction is normal. How we doing here? Bad. Yeah. Does that valve come up and hit the septum? Nope. There's some pretty decent looking sequentiality, but it's not moving much. How about back here? Do we see the septum coming into the LV? Nope. This is really easy to do. You can do a kinesis assessment very simply at the bedside. Anytime you've got a patient who's got hypotension, it's indicated to do this. How about this one? See how that septum's not even moving? I mean, that septal wall? Septal leaflet, thank you. It's not even coming up to this septum at all. And then these two things are just not squeezing together. Any questions about kinesis before I move on? Okay. This was a 2-day-old. They came in when I was doing my fellowship to Christ Hospital in Chicago. Came in with cyanosis. We did this subxiphoid view of the heart. This is the liver here. These are the atria. And this is the single ventricle. The differential diagnosis of a cyanotic neonate is pretty big. Lots of different things that can cause it. This happened to be a congenital heart defect that caused it. And so we were able to, very early on in the care of this patient, appropriately disposition them and call the right people, and the patient survived. We wrote it up as a case report. What's the diagnosis? Yeah, I like that. Tamponade, why? Huge clot there. So if this is the liver, and this is the right ventricle, left ventricle, this is what view of the heart? subxiphoid. The pericardium's out here. This is all isoechoic clot. If this happens, and we see this in our trauma bay, what do we need to do? Okay, so if his vital signs are unstable, we do and he's arrested, we do a thoracotomy, absolutely. If he's stable enough, he can go to the OR for a sternotomy thoracotomy. However, the one thing you don't do here is, if you work in a trauma center, the one thing you don't do is a pericardiocentesis, okay? Because that's not going to get the clot out of there, is it? The question is, what do you do if you have this and you're not at a trauma center where a trauma surgeon can come and bail you out of a thoracotomy? And I don't know the answer to that question. It's a tough question. It comes up when I'm teaching a lot. But all I know is that this really requires a surgical fix and not a procedural fix the majority of the time.
If I were in a non-trauma center, I would do a pericardiocentesis, recognizing that it's likely futile, but who knows what you're going to get, and you can't kill a dead person.
The next question is, would you inject any heparin into that pericardium once you were in there, or any urokinase or anything to that pericardial area?
Wouldn't work fast enough.
Okay.
The patient's dead in 3 minutes.
Should you wash it with saline and try to break it up with something? I don't know. People always ask me these questions. I never know the answer to it. Do you stick a guide wire down there and just start, I don't know, mush it up a little bit?
Turn up the ultrasound.
The power on the ultrasound? Yeah. Yeah, I like that. That's good. Pulverize it. Just start doing precordial thumps. I don't know the answer, but how about this one? Tough to tell. So this is the pericardium over here. I know you start to sound like a radiologist, clinically correlate. This is the RA. The RV is squished. The RV is really hard to see. It's actually squished. So this is tamponade. The question is, what is in here? Is it fat or is it clot? I mentioned briefly that fat is usually no greater than 1 centimeter in thickness. These are centimeter hash marks. Is the distance between the myocardium and the pericardium more than 1 centimeter? Absolutely. So right off the bat, I'm very curious. Is this isoechoic or heterogenic? Fat moves with the heart. It's heterogenic. Clot is isoechoic. Looks like the liver or the, thyroid. What do you think? This is clot. Hard to differentiate the two. And you're going to run across this more than really anything else.
But is fat going to ever collapse the ventricle like that?
Fat should not cause the ventricle to collapse, no. Very good point. So I see the trampolining ventricle. I see more than 1 centimeter thickness. I see an isoechoic substance in the pericardium. And I really start to make the case that this is a clot. And I see that the patient had a transmediastinal gunshot wound. No, I'm just kidding. Clinically, I am correlating. Okay, last slide. Is this second to last slide? Is this pericardial or pleural effusion? This is the peristernal long axis of the heart, RV, LV, LA. Okay, the myocardium is back here. Is that also the pericardium? Is that white line the pericardium or not? The answer is yes. This is posterior to the descending aorta. This fluid comes along, as Dr. Landorf is saying here, posterior to the descending aorta, and therefore, this is a pleural effusion. Confusing. I agree. It looks just like a pericardial effusion. If it wasn't for that descending aorta, how do I normally diagnose a pleural effusion on the left? Simple. I go into my my FAST exam window, looking at the spleen and the diaphragm. I look superior to the diaphragm. If I don't see the mirror image artifact of the spleen up in the chest, if I see all this black stuff on top of the diaphragm, looking coronally, laterally with the P21 probe, then I know, with the same probe I'm using for this, I know that confirms to me that this is pleural. I always do that.
Yeah, the problem is when you get a gunshot wound to the chest and you could have both a pericardial effusion and a pleural effusion, then you're really stuck.
Because the pericardium can drain into the pleura.
Yeah. Or it could have both of them, and tamponade could be your problem, or hemothorax could be your problem, or both.
Yep, and then it's thoracotomy. Thoracotomy time, yeah. Okay, guys. Turns out emergency physicians have a pretty low success rate of floating transvenous pacemakers blinded. You watch cardiologists do it, they do it like they could do it in their sleep. They do it like they're blinded. But they're so good at it. But emergency physicians, we struggle with this. Every once in a while, you get the patient who you can't transthoracically pace them. And their blood pressure is very low because of the bradycardia, and now it's time to fix that with electricity, but thoracically you just can't do it. So then that's the indication to do a transvenous pacemaker. There's a couple of others, but that's the main sort of clinical pickle that you end up in. Well, on ultrasound, you can see the guide wires coming into the RV. Not only can you help guide the guide wire in under this is a subxiphoid view, because that's the liver. Not only can you guide the guide wire, but you can also see when the electrical activity becomes mechanical capture as well. And so you can see all of a sudden when you get in the right spot and when you start to see the heart become mechanically captured. I wish I had the earlier part of this clip where the guide wire was coming in and then all of a sudden it started to capture, but nobody recorded that part of it. So that's what a transvenous pacemaker looks like. It's just something to consider if you're in the heat of the battle and you're trying to float this transvenous pacemaker somewhere wherever you are. Think about looking at it under ultrasound guidance so you can turn it and guide it to get it in that spot. Those pacing wires make very good reflectors of ultrasound. So bottom line, try to scan each patient at least 2 planes. If you're, parasternal long and subxiphoid, my 2 favorites. Those are the ones I go back and forth between. If I can't get subxiphoid because the liver's too small, then I'm going apical and parasternal. Any patient who's short of breath, hypotensive, anytime you're coding a patient, and of course, you want to save the windows. Any questions about cardiac ultrasound? All right, that's all I got. Thank you.